Hi, everybody. Welcome to this webinar. Thank you for joining, and good morning, good afternoon, wherever everybody is. My name is Anja Gippard. I'm the Executive Vice President for Medical and Scientific Affairs at the Elizabeth Glaser Pediatric AIDS Foundation. This webinar is one in a series of webinars that we host at EGPAF. For those of you who do not know us very well, our mission is to eliminate HIV and AIDS in children, youth, and families. And we do this through program implementation, innovation and research programs, advocacy, and technical assistance and capacity building efforts. We have activities in 19 countries, mostly in sub-Saharan Africa. In this edition of the Evidence to Action featuring COVID-19 and its impact on pregnancy and potential mother-to-child SARS-CoV-2 viral transmission, our senior HIV technical research advisor, Dr. ELynne Mofenson, will present the latest data on vertical transmission of SARS-CoV-2. For many, Dr. Mofenson doesn't need introduction, but for those of you who don't know her, she has been with EGPAF since 2014 and previously led the maternal and pediatric infectious disease branch at NICHD at NIH. Some logistical remarks. During the presentation, everybody will be muted, except Lynn, of course. We will open up for questions after the presentation and prioritize those questions that came in through the Zoom Q&A chat function. So at any time during the presentation, simply click on the Q&A or chat box at the bottom of your Zoom screen and enter your question and hit send, and we will collect those questions and address them at the end. If we still have time left, we will also open up for live questions. To ask your question, hit *9, and you will be notified when you are unmuted, and we would like to ask you to state your name and where you're from before asking the questions. If you have any technical difficulties, connectivity issues, please email publications@padaids.org and they will be addressed. And if we did not get to your question, also send your question to the same email address, publications@padaids.org, and you will get a reply within the day. Just also for everybody to know, this will be live streamed and recorded, and the recording will be shared at the end of this week. So without any further ado now, I would like to hand over to Dr. ELynne Mofenson for her presentation. Lynn, go ahead.
Hi, good morning, everybody. Good morning, good afternoon, good evening. So I'm going to talk about COVID-19 and pregnancy. And I want to start out by noting that data are extremely limited. They're very preliminary. Some are of very poor quality, and the data change almost daily. So I want to start out with some basic information on SARS-CoV-2. So what is a coronavirus? Coronaviruses are single-stranded RNA viruses that are named because of the projections or spike proteins on the envelope that resembles a crown. They're classified into 4 different genera based on genomic structure, can infect different hosts and have different tissue tropism. The gamma and delta CoVs infect birds, fishes, and a few mammals. Alpha and beta CoVs are the important ones. They infect only mammals, including humans, and have repeatedly crossed species barriers, with bats and rodents being the primary gene sources. There are 7 human CoVs known to date. 4 of them cause mild disease and 3 cause severe disease: SARS-CoV-1, MERS, and SARS-CoV-2, as shown on the screen. So comment on terminology. SARS-CoV-2, or Serious Acute Respiratory Syndrome Coronavirus 2, refers to the virus itself, whereas COVID-19, or Coronavirus Disease 2019, is the disease caused by the virus and was named by the World Health Organization in February. So this terminology is similar to HIV, which is the virus that causes the disease called AIDS. So how does SARS-CoV-2 cause infection? The human receptor for this virus is angiotensin converting enzyme 2, or ACE2, and this enzyme is involved in the regulation of blood pressure through catalyzing cleavage of angiotensin 2, which is a vasoconstrictor peptide, into angiotensin, which is a vasodilator peptide, and it's expressed by many cells in the body, but its principal target cell is in the lung. SARS-CoV-2 binds to the ACE2 through the spike proteins, as shown in this little figure, and it also subsequently downregulates ACE2 expression, which could have a negative effect clinically because you're basically enhancing vasoconstriction. This shows you a simplified replication cycle for the virus, and it's pretty simplified. So we start with fusion. So the spike protein binds to ACE2 and is fused into an endosome and brought into the cell. The genetic material of the virus, the RNA, is released, and then that begins to be translated by the host ribosomes into polyproteins. These polyproteins are then cleaved by a viral-specific protease, and some of them form a replication transcription complex, which enables the viral RNA to be replicated with viral RNA-dependent RNA polymerase. All of these proteins and the RNA enter the Golgi apparatus, where the viral envelope is assembled from their constituent proteins. The viral RNA binds to the N protein to form the ribonucleoprotein complex, and it buds out to form an intracellular vesicle, and then finally is released into the general area. So a pneumonia of unknown cause was detected in Wuhan in Hubei province in China and reported to the World Health Organization China country office on December 31st, 2019, and it was rapidly linked to exposure to the Wuhan seafood wholesale market. The epidemic doubled in size every 7.4 days, with transmission among close contacts rapidly becoming evident. And if you look at the graph, in blue you see linked to the market, and in orange you see cases not linked to the market. And by January, the vast majority of cases were no longer linked to that seafood market. There was then rapid spread out of Hunan to the rest of China, increasing from 5 cases on December 29th to 51,000 cases by February 16th, a 10,000-fold increase in less than 2 months. And then it rapidly spread outside of China to the current global pandemic. And in orange, you can see the cases outside of China in the graph. And the figure shows you the current epidemic as of yesterday. Over 1.8 million confirmed cases, over 100,000 deaths. So why is there such rapid global spread of this virus? Well, the first is the ease of transmission. It's spread through respiratory droplets and also touching contaminated surfaces and bringing those contaminated surface materials to your mucous membrane. And it has a high attack rate because it's infectious before symptoms, with viral shedding 1 to 3 days before symptoms occur. Prolonged shedding after symptoms, a median duration of 17 days, and with more severe disease, you have a higher viral load and a higher duration of shedding. And you can have transmission from asymptomatic persons, which was recognized only relatively recently. Also, there's a population lack of immunity. It's a novel virus. There's no herd immunity globally, so everyone is susceptible. And then finally, global travel leads to ease of importation of cases of a highly infectious disease. This figure shows you COVID-19 disease, and what I want to emphasize is that both the virus and the host immune response to the virus play a part here. And the symptoms here are based on the first 72,000 cases in China that were reported by Zhang in JAMA. So the first stage is the stage of viral replication. Clinical symptoms are mild constitutional symptoms, low-grade fever, dry cough, headache, sometimes diarrhea and loss of taste and smell, and some mild clinical signs including lymphopenia. In these China cases, no symptoms were reported in 1%, mild symptoms in 81%. You then begin to get a host immune response, and you get moderate to severe disease with shortness of breath, dyspnea, hypoxia, and you begin to get abnormal chest imaging findings. And then finally, you can get a cytokine storm where the host immune response takes over. You get acute respiratory distress syndrome, systemic inflammatory response shock, cardiac failure, elevated inflammatory markers, and you can see the difference in the chest x-ray between moderate and critical. The mortality is currently estimated between 1 and 3.8%, with risk factors being older age, male sex, and comorbidity. So just to emphasize that the majority of cases end right here in the viral response phase, the mild phase. Just wanted to point out that the virus can affect organs other than the respiratory tract, and these are some things that have been more recently reported. Neurologic manifestations include cerebrovascular disease, impaired consciousness, skeletal muscle injury. Cardiac injury has been reported, including 2 cases of COVID-related cardiomyopathy in pregnancy. Diarrhea has been reported in a minority of cases. Conjunctivitis has been reported. And then finally, the loss of taste and smell. This slide shows you risk factors for severe disease and poor outcome. The first showing you patient characteristics, and then abnormal vital signs, and finally abnormal laboratory. And as you've heard, the primary characteristic for severe disease is a history of some kind of chronic disease, but I want to just point out for HIV, there are only 2 case reports I could find in the literature as of yesterday of COVID-19 in HIV. So there's really a minimal amount of information that's known. And it's hypothesized that if you're on treatment, you have a high CD4, that COVID-19 disease would not be different than for those without HIV infection. But COVID-19 disease has been reported in low prevalence countries, China, US, Europe, and not yet in areas with high HIV prevalence. So we really don't know. However, we're now beginning to see COVID-19 in Africa, and it's going to be critical to monitor its impact in the HIV population. Just some brief comments on testing for SARS-CoV-2. The test that's been primarily used is a real-time nucleic acid amplification test, or RT-PCR, that detects the SARS-CoV-2 RNA, and that can be used in a variety of different fluids as well as tissues. It detects current infection with SARS-CoV-2. However, it doesn't detect whether that is infectious or not. It just is detecting the RNA. And it can be used to inform the individual of their infection status so that they can know that they're sick and take actions to prevent transmission. It can be used in the facility to inform patient management and actions needed to prevent transmission. And then finally, it can be used for public health purposes to inform actions to prevent transmission. More recently, there's been SARS-CoV-2 antibody detection, virus-specific IgG and IgM, and this shows past exposure to SARS-CoV-2, and that can be used to detect people who are susceptible, meaning antibody negative, and those who are supposedly immune, previously infected, antibody positive, to identify those who can be returned to work. It can be used to identify individuals with neutralizing antibody, and some treatments are using that, and to facilitate contact tracing and surveillance. There are no proven treatments for SARS-CoV-2, but there are many under study. And as of yesterday, there were 461 studies in clinicaltrials.gov. And these experimental treatment strategies attempt to interfere at different steps in the replication cycle. So for example, monoclonal antibodies and neutralizing antibody can prevent viral binding and getting into the cell. Camostat mesylate acts as it's a serine protease inhibitor, and it inhibits a receptor called TMPRSS2. And for entry of the virus through the non-endosomal pathway, which I didn't discuss in the prior slide, it cleaves the spike protein to activate it. And this particular drug inhibits that, that trypsin enzyme. Chloroquine and hydroxychloroquine decrease acidity in the endosome, so would interfere with the virus being able to get uncoated. Cell culture studies suggest that you need high doses for this. Lopinavir, ritonavir, and other protease inhibitors, notably atazanavir and darunavir, can inhibit the protease enzyme. And remdesivir and favipiravir inhibit the viral RNA polymerase. And then finally, we have immune response modulators that are used to modulate the cytokine storm. And these are primarily monoclonal antibodies that are used for treatment of other diseases like rheumatoid arthritis. This shows you the 461 clinical trials as of yesterday. The vast majority are in China, in Europe, and the US. And I just want to comment that the more things change, the more they stay the same. All of these trials generally exclude pregnant and breastfeeding women and children. So we'll have good information about the effectiveness in adult men. Randomized trials are needed to discern efficacy and safety, and the scientific data really rapidly change every day. So in March 18th, we had a trial of lopinavir ritonavir in adults with severe COVID that showed absolutely no benefit. April 4th, there was a trial, a comparative study looking at hydroxychloroquine in hospitalized patients that showed no benefits and actually an increased need for respiratory support. There was another paper on April 11th looking at chloroquine, looking at a higher dose of chloroquine, finding no benefit and that the higher dose was harmful. And then finally on April 10th, there was finally some encouraging data looking at compassionate use of remdesivir and finding that it had the suggestion of some clinical benefit. And there are a number of randomized trials that are ongoing. So that's the basics. I want to now talk about COVID-19 in pregnancy. Data are limited, they're preliminary, and also potentially duplicative. And there have been 3 to 4 reviews and meta-analyses, but only small numbers, 23 patients, 38 patients. I think the largest was less than 100. And so I did a rapid review in PubMed, MedX, RIV, and Science Direct to identify reports in pregnant women and their infants, including case reports using the terms COVID-19, SARS-CoV-2, novel coronavirus, and pregnancy or newborn. And these are data published as of yesterday. 37 patients were identified, including 475 pregnant women with COVID-19. 28 of these patients, including 82% of the patients, come from China. These papers are generally relatively poor quality, unclear amount of duplicative reporting because 15 of the patients, including 259 women, come from overlapping institutions and overlapping time periods. And so you really can't tell whether they're duplicative cases or not. There are now 4 reports from the US on 80 patients, 16%, and then 1 case report each from Korea, Turkey, Spain, Honduras, and Sweden. This shows you the characteristics of pregnant women with COVID-19. And these tables will all show you the characteristics, the number of patients, and then the number over the total sample and percentage. So 405 pregnant women, 87% of those are RT-PCR confirmed, and 13%, or 64 women, are clinical diagnosis. These come from China, and a clinical diagnosis is defined as a suspect patient with a typical chest CAT scan, but a negative RT-PCR test or no RT-PCR test. Maternal age was 22 to 42 years. Gestational age at presentation of symptoms was 6 to 41 weeks. But if we look at trimester of infection, the vast majority are third trimester, 91%. 8% in the second trimester. There were 4 reported in the first trimester, but they all had induced abortion, so pregnancy outcome there is not known. 413 of the 475, or 87%, had a pregnancy outcome reported, including 4 abortions and 1 stillbirth, and 13%, or 62 women, were still pregnant at the time of the papers. This looks at timing of symptom onset in the pregnant women, and antepartum onset was reported in 78%, starting 1 to 10 days prior to admission. Intrapartum onset of the first symptom was described in 2%. Postpartum onset of their first symptoms in 8%, 1 to 3 days postpartum, and no symptoms in 12%. So although the majority presented with symptoms while still pregnant, 10% didn't have symptoms until they were admitted in labor or after delivery. Additionally, 12% had no symptoms at any time but screened positive by RT-PCR, and they were screened either because they had known exposure, or in New York City, they're doing universal screening, and I'll present you this data. This was published 2 days ago in the New England Journal. And this is from New York Presbyterian and Columbia University Hospital in New York City, reporting on 215 pregnant women who delivered, and they're doing universal nasopharyngeal RT-PCR testing in labor. 4 of the 215 women, or 2%, had symptoms. All were found to be positive. 29 of the 210 who were tested who had no symptoms were also positive, 14%. Thus, 29 of the 33, or 88%, who were positive by PCR had no symptoms at admission. And fever developed postpartum in 3 of the 29, or 10% of those who initially didn't have symptoms. So we haven't really done surveillance screening in the US yet to know the numbers that are asymptomatic. And we also don't know whether, if you're asymptomatic and you've got PCR, whether you are infectious or not. This slide looks at the type of symptoms in pregnant women with COVID-19. Antepartum fever was the most common in 44%, postpartum fever in 37%, cough in 33%, myalgia 22%, fatigue 15%, shortness of breath and dyspnea 14%, sore throat 11%, gastrointestinal, primarily diarrhea, in 9%, chills in 7%, and as we talked about, no symptoms in 12%. And you'll notice that the number of papers that actually report symptoms are many less than the 37 papers that were published. Now, this compares COVID-19 symptoms in non-pregnant adults to pregnant women. So these are over 55,000 adults with lab-confirmed COVID-19, and these are the women from the survey that I did. Blue is fever, orange is cough, gray is fatigue, yellow dyspnea, blue sore throat, green myalgia, dark blue chills, and brown is GI. So you can see 88% of adults had fever, but 45% of this was early. And in pregnant women, 81% had fever, 37% antepartum early, and 44% late. And then if you look at these curves, you can see pregnant women with COVID-19 do not appear to have major differences in symptoms, maybe slightly less cough and fatigue compared to non-pregnant individuals. These are laboratory findings in the pregnant women, and again, the number of studies is relatively small. Low or normal white cell count in almost 70%, lymphopenia in 42%, increased C-reactive protein 60%, increased transaminases in 8%. In terms of radiology, in China, the preferred radiology test was a chest CT, so very few chest x-rays were reported. Reports on chest x-rays primarily come from the US. And 88 to 100% who had an x-ray had abnormal findings. So again, we're going to compare adults with COVID-19 to pregnant women with COVID-19. In blue is low normal white count, orange is lymphopenia, gray is CRP, yellow LFT, and green is abnormal CAT scan. And again, you can see pregnant women with COVID-19 lab findings are basically similar to that in non-pregnant individuals, and lymphopenia and elevated CRP, both in non-pregnant and pregnant women, appear to be important markers, and most people have abnormal radiologic findings, but of course these data are skewed towards evaluating symptomatic individuals. This looks at disease severity in pregnant women with COVID-19, and this is really difficult to get from the papers. 16 papers talked about oxygen support. 48% of people in these papers required oxygen support. Mechanical ventilation was rare, 2%, 9 women, but 3 of those 9 had not resolved at the time of publication, and there were no deaths. So the majority of pregnant women had mild to moderate disease, 52% requiring only supportive care without the need for oxygen. A significant minority, 2%, had severe disease requiring intubation. And although there were no deaths, 3 of these, that should be 9 patients requiring ventilation, were still receiving ventilation at the time of paper publication, including 1 getting ECMO. So pregnant women can get severe disease, but it doesn't appear to be elevated. And again, comparing adults with pregnant women, blue is no symptoms, orange is mild, gray is moderate to severe, yellow is critical, and green shows you mortality. And just to comment that in the pregnant women, you couldn't really differentiate mild from moderate to severe. So this is put together, and so this is compared to moderate, severe, and mild put together. And you can see from this that pregnant women do not appear to have more severe disease than non-pregnant adults. A higher percent look asymptomatic, but this is because some sites are doing universal testing regardless of symptoms. And there's no increase in mortality, no mortality in the pregnant women, and in individuals aged 20 to 44, the mortality is only 0.2%. This looks at pregnancy outcome in the women, and I just want to note that of the papers in whom we could discern what trimester it was, you really had most in the 3rd trimester, 91%, a few in the 2nd trimester. So the effect of infection in the 1st trimester and early pregnancy is really not determined yet. We don't have any reports on that. So in these women, 15% had fetal distress, 11% premature rupture of membranes. There was 1 stillbirth, which gives a rate of 0.4%. The vast majority were born by cesarean section, but that's because in China, COVID-19 is viewed as an indication for cesarean section. There were 380 births, including 6 twin sets. 24% were preterm, 9% were low birth weight. This looks at outcomes of the newborns. Neonatal asphyxia and neonatal death were very rare. There was only 1 death, and this was in a preterm 34-week gestation infant with multiple organ failure, DIC shock. that died at 9 days. No RT-PCR was done, but it was a pretty premature infant. Neonatal symptoms were reported in 20%. These were very vague. Fever in 29%, respiratory distress 45%, GI 26%, but notice that very few papers really reported on what the symptoms were. And in the 120 that had an X-ray, 23% had an abnormal chest X-ray, but chest X-rays were generally performed in infants who had respiratory symptoms, not asymptomatic symptoms.
Lynn, this is Anya. We can no longer hear you. Did you maybe accidentally?
No, can you hear me now?
Yes, thank you.
Okay. Do I need to go backwards?
2 slides.
Two slides?
Just to the last slide, yep.
This one? Okay.
Yeah.
So I was just pointing out that in utero infection requires the pathogen to cross the placenta, and I was asking, is there a receptor in the placenta? Is there a receptor in the fetus? And this is the placenta. So this is immunohistochemical localization of mRNA for ACE2. So the brown shows you the mRNA. And ACE2 was found in the placenta localized to the decidua and the chorion and in the intervillous spaces. And it's also found not just early in gestation, but also late a term. These are from later term, and you can see again in the decidua and placenta. And ACE2 enzyme can be found in the fetal lung. Again, looking at immunohistochemical localization with the brown showing you ACE2. It's found as early as 12 weeks gestation with an increase over gestation and postnatal development. What about intrapartum transmission? This requires fetal exposure to infectious virus. So the question is SARS-CoV-2 found in vaginal fluids? Minimal data. There's one study of 10 postmenopausal women with severe COVID-19 that had testing in their vaginal fluids with RT-PCR 17 to 40 days after diagnosis while still in the ICU. All samples were negative. We have data from 6 pregnant women at delivery to date, and all 6 were negative for virus. But just to point out that potential exposure to the virus after birth in the delivery room is possible, but that's really postnatal and not intrapartum infection. What about breast milk transmission? SARS-CoV-2 PCR was evaluated in 14 breast milk samples, all tested negative for virus. And postnatally transmission looks like it's more likely through close contact with the infected mother of the infant than through breast milk. So what's the immunologic evidence? So there have been reports of 7 neonates with SARS-CoV-2 IgG and/or IgM, but negative RT-PCR results. And I'm just going to briefly go through the cases. Infant 1 was 38 weeks, born by C-section, negative pressure room. The mother supposedly wore a mask. Infant had no contact with the mother. The mother had high IgG and IgM in their serum. The infant was asymptomatic, but had both IgG and IgM at age 2 hours, as well as elevated cytokine levels and leukocytosis. 5 nasopharyngeal swabs taken from 2 hours to 16 days of age were all negative, as was breast milk, so no virus found. And at day 24, the IgG had significantly decreased and IgM was almost gone. Normal is less than 10. Infants 2 through 7 come from one report from China. These are 6 infants, again born by C-section, negative pressure room, mothers wearing masks, separated immediately after birth. 2 of the infants had elevated IgG and IgM, and both mothers had elevated G and M. 3 infants had elevated IgG but not IgM. All of these mothers had elevated IgG, and 1 infant had elevated IL-6 only. All of them had negative RT-PCR on nasal swabs and no symptoms. So comments on these cases. IgM antibodies are too large to cross the placenta, so detecting it in the newborn could be assumed to reflect fetal production following in utero infection. So evidence for transmission is based only on elevated IgM antibodies in blood drawn following birth. Elevated levels of IgG and IL-6 may be from transplacental passage from the mother. However, IgM assays can be prone to false positive and false negative results along with cross-reactivity and testing challenges, and none of the infants had a positive virologic test, so there's not virologic evidence to support the serologic suggestion of in utero transmission. And the decline in IgM in one case in 14 days is very unusual kinetics for IgM. With congenital Zika or rubella, IgM antibodies usually persist for a year or more. So serologic cases are not definitive proof of in utero transmission. Virologic evidence. So this is the data of virologic testing by RT-PCR. 32 neonates had swabs, 11 of them were positive for a transmission rate of 4%. Amniotic fluid, placenta, cord blood, gastric aspirate, maternal breast milk, and vaginal swabs, all negative. And of 44 infant stools, 5 were positive for 11%. So I want to briefly go over the cases with the viral positive results. The first infant, 38 weeks gestation, born by C-section due to severe preeclampsia. The mother was not diagnosed until 5 days postpartum. Infant had initial respiratory distress, resolved on its own, transferred to the mother and breastfed until they realized the mother was infected. At that time, the infant was asymptomatic and had a negative nasopharyngeal aspirate, but 2 days later had a positive aspirate. Had minimal symptoms, but had an abnormal chest x-ray. Symptoms resolved within 24 hours, child asymptomatic, but the aspirate was still positive at day 13. Infant 2, another C-section, another mother wearing masked, and infant isolated. Again, the mother's PCR returned late at day 3, and the infant had a swab at 36 hours, which was positive. The infant had no clinical symptoms, but a chest x-ray, quote, consistent with pulmonary infection at 53 hours, which resolved. There's a lot of chest x-rays with, quote, mild infection that they never describe what it really is. This child had negative tests at 4, 8, and 15 days. The third infant, similar, 39 weeks, born to a mother, RT positive, 36 hours. No real symptoms, but an abnormal chest x-ray, and then turned negative. Infant 4 was a 40-week infant born to a mother with fever, abnormal chest x-ray, wore a mask. Mother found to be positive, infant was swabbed at age 36 hours. Asymptomatic again, but having some abnormal chest CTs, which improved. And the next swab of the infant was negative at day 14, and all other samples were negative. Infant 5, again, a similar report, a brief period of nondescript symptoms, normal lab results, chest x-ray with, quote, pneumonia, positive tests at age 2 and 4 days, negative at day 6. The next 2 infants, again, very similar. Immediately after birth, separated from mother, mild symptoms, chest x-ray abnormal, positive at day 2 and 4, negative at day 6. Infant 7 was a premature baby who had symptoms that were probably due to prematurity and sepsis with Enterobacter. had NP and anal swabs positive at 2 and 4 days and negative at 7. Infants 8 and 9, 2 infants with swabs collected post C-section after birth had positive tests. One had, again, pneumonia on chest x-ray, the other asymptomatic, and no other tests. And the last 2 had nasopharyngeal swabs collected at age 30 hours and another at 4 days. Similar, born by C-section, isolated. One had mild symptoms of shortness of breath. The other were asymptomatic, but supposedly had abnormal CT scans, and repeat swabs were negative prior to discharge. They also reported on infants with anal swabs, but no one knows what that really means. So comments on these cases. The first case from Spain is likely horizontal transmission, as there was breastfeeding from infected mother for 3 days prior to the test. 8 of the 10 remaining cases report operative delivery and separation from the mothers. Aside from the preterm infant we talked about with RDS, all the infants had minimal symptoms, but some poorly described radiologic findings was resolved quickly. 5 of the 10 had a single positive test followed rapidly by multiple negative tests within 2 to 14 days, and no virus was detected in any other fluid except stool. So it's possible in utero infection, but also possible false positive tests. So I thought that this was very helpful, looking at what can we use to define whether there's in utero infection. And this comes from a recently published article, and she accounts for both maternal testing, whether there's symptoms in the infant, whether there's detection of the virus, including the type and timing of the sample, with blood and amniotic fluid being more important than the placenta or nasopharyngeal swabs, and whether there was antibody. So she starts out, if the infant has clinical features of infection and you know that it was born to a mother with SARS-CoV-2, confirmed infection requires detection of the virus in blood or amniotic fluid at birth. Probable infection is detection by NP swab at birth and having a placental sample positive. Possible infection is no detection at an NP swab at birth, but having IgM antibodies in the cord or blood. Unlikely, no virus by PCR in the nasal swab and no antibody testing, and not infected, you can see. If the infant has no clinical findings of infection, again, detection of the virus in blood at birth is required for confirmed. Detection in amniotic fluid is probable. Detection of IgM in cord blood is possible, and onward. For intrapartum infection, if the infant has clinical features, to be confirmed, you have to have virus in an NP swab at birth and age 24 to 48 hours. Probable is at birth, but not at 24 to 48 hours. Possible is no NP swab, but detection in other samples, etc. And then they go to infant with no clinical features. Confirmed is detection at NP swab at birth and age 24 to 48 hours. Here we have at birth for possible. And lastly is the definition of postpartum infection, that she says the infant has to have clinical features and a parent with infection or symptoms but not tested. And here, detection of the virus in an NP or rectal swab at greater than 48 hours of birth in an infant who tested negative at birth. Probable is detection of virus at greater than 48 hours of birth in an infant who was not tested at birth. So if we look at the cases that I described to you, we see the cases here, the mother's test, the infant symptoms, birth samples, type of sample, timing of samples, and later tests. So of those with the positive virologic test, none of them meet the definition of confirmed or probable intrauterine infection, as none of them had birth blood or placental samples or an antibody test done. 2 of them met the definition of possible intrapartum because they had a test at 24 hours with no second test in an infant without or who had minimal symptoms. And you see most of these kids, you can't tell what symptoms they had. And then 9 may meet the definition of probable postnatal infection if you view 30 to 36 hours as equal to 48 hours. And probable postnatal was detection in NP in the neonate not tested at birth. The immunologic cases meet the definition of possible in utero infection. They all had IgM in cord blood and negative detection of virus in blood. So what can we say? So the serologic data are not definitive, but are suggestive. We do know that there are ACE2 receptors on the placenta and in the fetal lungs, suggesting it's possible for in utero transmission. The viral data are suggestive, but there were no birth testing and rapid conversion from positive to negative within a few days, which is concerning regarding the potential for false positive tests. So is it possible? We can say yes. Do we have definitive proof? I would say not at this time. And I wanted to end with what I thought was a nice description of the management of suspected women with COVID-19. So you start out with the mother who's got suspect symptoms, including some of those infrequent symptoms, and you do nasopharyngeal and oral swabs. If the mother tests positive, she should get a mask for source containment. If severe symptoms, ICU support. You minimize the number of providers in the delivery and operating room to reduce the exposure risks, and neonatal providers in particular should have personal protective equipment for airborne precautions should they have to intubate. The infant should be isolated post-delivery and cared for in a single room pending their test result with NP and throat swabs at birth, 24 and 48 hours. If the infant tests negative, which most infants appear to do, they're discharged to a caregiver pending a negative test and symptom resolution in the mother. If the infant tests positive and they have no symptoms, and most infants who test positive have minimal symptoms, they can be discharged and potentially quarantined at home, avoiding care by elderly or those with comorbidity. And if they have symptoms, they go to the NICU. And in terms of infant feeding, both the WHO and CDC say that healthy caregivers can feed expressed breast milk using a dedicated pump, strict hand hygiene. But if the mother and infant are not separated, breastfeeding while wearing a mask and after hand hygiene may be considered. And I just want to bring to people's attention that the perinatal guidelines panel has issued interim guidance. Actually, the adult perinatal and pediatric panel have issued interim guidance for persons with HIV and COVID-19 that include issues related to pregnant women and children, as shown here. And that's it. Thank you. Hopefully everyone was able to hear that.
Yes, Lynn, we did. This is Anya.
Okay.
Thank you, Lynn.
You're welcome.
Sarah, are you taking over?
Yeah, so hopefully everyone can see this Q&A slide on their screen. So we just wanted to remind you all that we would love for to have your questions. We have 10 minutes until we mark the official end of our webinar. I'm not sure, Lynn, if you're able to go over a little bit or not, but we will be prioritizing the questions in the Q&A box that we've been getting thus far. And you can, if you still have questions that you haven't submitted, feel free to put those in the Q&A box. And I believe Lynn is going to go through them and answer what she can.
Okay.
If we have time afterwards, we could go to the phone, but we've have a ton of questions so far, so I think we're probably just going to stick with the Q&A.
So
I did want to remind everyone that if they want to ask another question, that you can email publications@pedaids.org, and we can get your question answered by the end of today.
So you want me to go through the Q&A box that I can see then?
Yep.
Yes?
Thanks, Lynn.
Okay. Starting out here, I just want to point out I am not an expert in coronaviruses. This is all from my reading and that kind of, so some of the questions I'm not going to be able to answer without going and looking things up. So the first question is, current data show an increased mortality among African Americans. Is race, ethnicity a risk factor for increased mortality? And I think that most people feel that it is not race and ethnicity per se, but it's poor access to healthcare and increased comorbidities, higher rates of diabetes, higher rates of hypertension, et cetera. And I believe that that's the latest feeling, that there's no genetic aspect here. It is more socioeconomic. The second question was, is cardiomyopathy in pregnancy specific to gestational age? So very few, if any, reports of people infected during the 2 cases of cardiomyopathy I reported. They were both in 3rd trimester women who had symptoms at the time of delivery. Next one asks, what are the viral structural differences between SARS-CoV and SARS-CoV-2? So there are some differences. I don't know exactly what the genetic differences are. I think that it's called SARS because the genetic resemblance is closer to the SARS than the MERS virus. Question on the sensitivity and specificity of the RT-PCR, which is a very good question, and I don't have the answer. No test is 100% sensitive and 100% specific. And I believe that there are a variety of RT-PCR tests out there. And I don't know that all of them have had their sensitivity and specificity tested. Okay, on severity of disease, did any publication review compare pregnant women versus adult non-pregnant women? Not specifically, but the graphs that I showed that compared adult non-pregnant individuals included both men and women. But there wasn't anyone that just gave you, here's what's on women, at least that I saw. How do symptoms and mortality for pregnant and non-pregnant women compare as compared to all adults? Are women who are not currently pregnant included in the clinical trials? And are there not regulations to report inclusion of women who are and are not pregnant? There's no, CDC probably has some division by sex, but I don't believe there's a difference in mortality between women and men. What I showed you was the overall adult mortality, and for that particular age group, the age group of women of childbearing age, 20 to 44, the mortality is only 0.2%. Yes, women who are not currently pregnant are included in the trials if they are on contraception and they're not breastfeeding. And there is no regulation that requires inclusion of women who are pregnant, although a number of people think that there should be. I came in a bit late. Have you compared with the general study population, or have you tried to match pregnant women with non-pregnant women? No, I have not. I've not tried to match pregnant women, and it's hard enough to be able to get the data on the pregnant women, let alone trying to go into the COVID-19 cases in adults and distinguish men and women. So I haven't done that yet. And I agree, it would be good to be able to do that. What could be the explanation for survival mild infection seen in those infants whose immaturity is immature? So I guess the answer is, do we have any infections in those infants, really? I think we don't have enough data right now to be able to say that we have infection or not. I can say that there have been, there's at least 1 or 2 deaths in the US in neonates who had proven infection. I believe, acquired postnatally. So children can be sick, although they appear to have milder disease. This keeps moving here. It says in Latin America, some women have had deaths. Late diagnosis, different from China or Europe where there were no maternal deaths. I have not seen any publications from Latin America showing pregnant women mortality. But if we say that the disease is similar to non-pregnant individuals, in that age group, the mortality is 0.2%. So one would expect that if you had a large enough number of pregnant women that you would see some mortality given a 0.2% mortality. Any advice for pregnant healthcare workers? I think it's the same advice that one gives any healthcare worker, which is to use protective equipment. I think that at least one of the papers that I showed you, that last paper, may have specifically discussed pregnant healthcare workers, and I can try to go through the papers to see whether there was something that gave specific evidence. I don't recall that the advice was any different. This question says, I'm 36 weeks pregnant, I haven't gotten tested, and I have no symptoms. Do I need to be scared to give birth in the hospital? So I don't know where you live. Stop moving that, I can't see. So I think, you know, part of the answer is where you live. In New York City, if you go to the hospital, you'll get screened. Is there a possibility to be contaminated while in the hospital? I think that would be unusual. Most hospitals have in place good infection control and disinfection measures, and I think the chance of getting infected in the hospital is much, much lower than the chance of having an abnormal birth outcome if you have a complicated pregnancy and delivery and you're not in the hospital. Postpartum symptoms. So some of the postpartum symptoms were in women who tested negative before giving birth and then then became positive postnatally. And then some were in women who tested positive and then first had infections. So both of those were seen. Can steroids be used in the treatment? So right now, my understanding is that the Infectious Disease Society of America just issued guidance on treatment and management that you can find on the IDSA webpage, and they recommend that steroids not be used in the treatment. There's concerns that it actually makes it worse. People are looking at these monoclonal antibodies, anti-inflammatory monoclonal antibodies in clinical trial. General advice on mode of delivery. I think this is asking what factors would you use for mode of delivery. I think that that the factors deciding on mode of delivery should be based on obstetric parameters. That I don't know that there's any reason to say that C-section is more, quote, preventative of intrapartum transmission than vaginal delivery, given that a number of the kids with the positive tests came from C-section. So I think that you would just follow routine obstetric care. Do I think all pregnant women should be routinely screened? That's a good question. Certainly the data from New York City suggests that if you're in a city with a heavy COVID-19 burden, that makes sense to do. From the healthcare provider perspective, it sounds like if you're in such a situation, you should be using personal protective equipment for all deliveries, not just ones in which you know that there's COVID-19. I don't know that the routine screening question is answered, but it certainly seems to me that if you're in a city like New York City, it would make sense. Yeah, so the question is about HIV positive pregnant women with COVID. There are the only two things I could find on HIV positive people and COVID were the two papers that were case reports from China that basically said very little. I have not seen any data on HIV positive pregnant women. The next question asks if there's any documented positive placenta cord blood. The answer is no. Very few, under 20 tested, but no. Did any study look at confirming the source of infant COVID and assuming babies could have acquired infection from other contacts? So one or two of the cases I presented with the virologic tests, at least one had horizontal contact, the other one had breastfeeding. So a number of those infants could have acquired infection outside, but a number of the infants, the authors wrote that the mother wore a mask, it was in an operative delivery room, the infant was isolated immediately.
Lynn, I think we lost you again.
Lynn? I think you might have been muted again.
Am I back?
Yes.
Hello? Okay.
Thanks, Lynn.
All right, sorry, it was my screen's acting funny. Do you want me to continue with the Q&A?
Sure, yeah, that would be great. We can do it for maybe until 8:05. We'll just do two more minutes of questions. Thanks.
Okay. Next question was any indication why induced abortion in the first trimester? The answer is no. It just said that there was an abortion. Specific prophylaxis? No. I think if you're looking at prophylaxis, we really need to look at the randomized clinical trials. There are several that are looking at the potential to use hydroxychloroquine, but there are no data yet showing that anything is a good treatment or a good prophylaxis, so I wouldn't use any of those drugs. Is vaginal delivery feasible and possible? Yes. Yeah, I think there are some women who were described in these papers who had vaginal delivery and had an infant who tested negative and did fine. So I think delivery should be based on obstetric indications. Any risk with comorbid malnutrition? Risk of COVID? I think that things that would make you immunosuppressed would potentially make you more likely to have severe disease. It's this, the factors here are not associated with an increased risk of infection. It's an increased risk of severe disease with infection. So just remember that. And there wasn't really anything that talked about malnutrition. Use of non-medical masks for pregnant women when accessing care. I don't, right now in Maryland, in Montgomery County, they're requiring you to wear a mask when you go into a grocery store or when you go on the metro, and I would wear a mask when I went into the physician's office. That's just a personal feeling. Do you think HAART will be protective? I do not know. The question of whether protease inhibitors are a good treatment is unresolved. The in vitro testing does not necessarily result in vivo efficacy as we saw with lopinavir ritonavir. So I would wait until I saw data from trials, and until we have data from countries in which HIV is more endemic because we have very few cases in HIV-infected individuals. Communication, what should be the message regarding mother-to-child transmission? I think the message has been we don't know if it occurs, and I think that's still the message. If it does occur, it appears to be infrequent. Based on the data that I showed you, it was about 4%. But I don't think that the data are definitive, so we could say, is it possible? Yes. Has it been shown? Not yet. Asking about participation of women in the trials. So the women can participate in clinical trials. None of these clinical trials have yet had results. I have heard that the Remdesivir trial may have results relatively soon. Any positive children from the mother part? No children in these trials. It's non-pregnant women who can participate and no children yet. Comorbidities that could have influenced the outcome and severity. I forget, did I not show the comorbidities? I guess I didn't. There were a number of women who had preeclampsia and gestational diabetes and gestational hypertension. There were a number of women with chronic conditions. The problem is that the papers do not describe this very well, and the papers from China, where the majority of the data come from, look duplicative, so I can't discern whether it's the same women or not. Do you want me to keep going?
I think, Lynn, we can stop there, and
Okay.
we will take note of all of these questions and reach out to everyone. I think what we'll end up doing is probably through our technical listserv sending out this sort of Q&A as it is right now and provide you all with answers. If you're not on that listserv, again, please reach out to publications@petaids.org to get on it, and you can reach out to us privately to access any of the resources Lynn used today. We're also going to be, I wanted to flag this for everyone, developing a resource library on our website where a lot of this research will be located. The recording to this webinar will be located there, and any other future materials that we publish will be presented there as well. And we'll be sharing that resource library through that email listserv. So again, if you're not on it, reach out to publications@petaids.org. And thank you so much, Lynn, for this presentation. One person in the comments called you an international treasure, and I would agree. Thank you so much.
Thank you. Bye-bye.
Bye. Thank you. Thanks to everyone who joined.
Thank you, Lynn.